By definition, patients who have more than 10% plasma cells in the bone marrow have smoldering without symptoms have smoldering myeloma. Recently, we've discovered that there are a group of those patients who will go on to get myeloma more frequently, and we can define that as patients who have more than 60% plasma cells in the bone marrow, a serum free light chain ratio greater than 100, or the presence on an MRI or PET scan of a lytic bone lesion. We feel that those patients today should be treated as if they have active myeloma. At the ASH meeting here in 2017, there were some new abstracts suggesting that genetic factors could also be used to predict who is going to respond, who can be watched and who could be monitored without treatment, and which patients should probably have treatment today. They include looking at the oncogene called MYC, and they included some other signatures that have been derived from gene expression profiles. If you do decide, there's been a lot of interest in asking the question is, if we take these high-risk smoldering patients, should we treat them, or should we continue to watch and wait for the 2 or 3 years until they get active disease? There were abstracts at this meeting that described very aggressive approaches to treating smoldering myeloma, but I think the message for community physicians and others watching is that for most cases, we should continue to watch and wait and not treat these patients unless they have some of these new criteria present. We need longer follow-up on clinical trials, and while it's an exciting concept, it needs to be matured before it becomes part of the standard practice. The clinical studies that have been presented initially to treat smoldering myeloma were using single-agent drugs like lenalidomide or even now daratumumab. I think probably a more convincing strategy is to treat these like they have active disease. And in fact, the Spanish group at this meeting described using carfilzomib, lenalidomide, dexamethasone, transplant, and then consolidation with the same drugs, a very aggressive strategy to see if you could actually eradicate or cure the disease. If it were my choice and I did choose to treat a smoldering myeloma patient because I was worried about their risk of progression, I would tend to go all in and treat them as if they had active myeloma. Monitoring of patients with myeloma mostly involves using blood tests. We use those to monitor the level of the serum monoclonal protein, or increasingly the serum free light chain. We find the serum free light chain actually to be very helpful. It actually tends to be the thing that changes first. It will go up first in relapse, and it will come down first in patients who are responding. The half-life of the larger monoclonal protein can be quite long and take longer to change. We usually monitor that every month. In patients who are on more of a maintenance strategy, we can move that to every 2 months, but usually not much less frequently than that. For patients who are off treatment, we perhaps move to every 3 months monitoring for convenience for the patient and their family. But one other change that has happened recently is the use of minimal residual disease testing. This does require a bone marrow exam, so we tend to do that less frequently. Generally speaking, maybe every 6 months or 12 months when we're looking for minimal residual disease in the bone marrow and just whether it changes or not over time. PET scanning has also become more common. We used to just use skeletal surveys, a plain x-ray of all the bones in the body. Now we use a much more accurate and sensitive test called PET-CT scanning. This is usually done at diagnosis and at multiple decision tree points throughout the treatment course. And the value of that is to pick up disease growing outside of the bone marrow, which has also become more common as our treatments have improved.